recording first.
Hi everyone, good morning, good afternoon, good evening, wherever you may be. It's a real pleasure to be welcoming you to this next CSF series. My name's Maya Buch from the University of Manchester, and today we will be focusing on the second in a series of updates on the clinical management of JAK inhibitors in inflammatory arthritis, with a particular focus on implementing regulatory updates. I'm just trying to progress my slides, so do bear with me for a moment. So, thank you. So, in addition, we've got a great faculty. Those of you that joined the first webinar will remember, so joined by Chris Edwards from Southampton in the UK, Anja Strangfeld from the Charité University Berlin, who's also co-founder of the Rabbit Registry, and also Lorenzo Dagna from the Rheumatology Allergy Rare Disease at San Raffaele, Milano. So we've got a great faculty and some great expertise and insights really to contribute to this session. Next slide, please. So just some housekeeping before we get started. You'll all be on mute for the duration of the meeting. Please do contribute to questions. It's what makes really this webinar so productive and enjoyable. So questions to the speaker and to the panel can be submitted at any time throughout the course of this webinar through the Q&A function. And if you do have any questions or queries, or if you're having any difficulties, please use the chat box, as you can see on the bottom right, and you can be alerted and guided through any technical difficulties. So this is the format for today's meeting. We'll be kicking off shortly with Anja, who's going to give us a background on the long-term safety data and the FDA labeling for JAK inhibitors in rheumatoid arthritis. And then that will be supplemented and consolidated by Chris Edwards, who will talk on the European PRAC review of JAK inhibitor data. We'll then have Lorenzo, sorry, there's just an omission there. We'll have Lorenzo, who will speak to the clinical impact of these regulatory updates in terms of our day-to-day management, so the relevance and the impact this has on our decision-making with our patients in real life. And then we'll wrap up with a good time for discussion. I think it will actually lead to a whole load of pertinent questions that reflect the complexities on how we interpret regulatory updates in the real world. So I'm not going to delay any further. It's a real pleasure to introduce Anja, who's going to be talking on the long-term safety data and FDA labeling. Anja, over to you.
Thank you very much, Maya. And I also welcome everybody at the screen very heartily. And I say good afternoon. It's good afternoon in here, late afternoon in Germany. My part in this webinar, as you already heard, is long-term safety data and also some spots on the FDA labeling on JAK inhibitor safety in RA. And these are my disclosures. And I want to start with randomized controlled trials and long-term extension studies and analysis of the data that comes from then. I also want to show you some real-world evidence, and then I want to come to the FDA labeling. The first study I want to show you is an integrated safety summary of 19 completed RCTs and two long-term extension studies. They included data up to 2017 with a maximum exposure of 9.5 years of tofacitinib, and more than 7,000 RA patients were included overall. The authors looked at several outcomes. One of it is serious infections, and you can see the incidence rate with 2.5 and 2.3 without herpes zoster is somewhat what we expect also from BDMA treated patients. And the most frequent events were pneumonia, herpes zoster, urinary tract infection, and cellulitis. And this is also what we see in our registers regarding biologic treatments. And you can see here rates in different time exposures. And something I want to point out, looking at that graph, is that we should not see it as a time as a long-term exposure or as a time variant, but we should always keep in mind that serious infection rates that are shown here are only true for this period they are indicated in, because the number of patients we have at the beginning is not the same as the number of patients we have, for example, after 5 years. So after 3 years, only 50% of the patients that were looked at the beginning are still in the analysis. But nevertheless, what I really like in this study is that risk factors for serious infections were looked at in great detail. For example, the authors found out that a risk factor for serious infections is the lymphocyte cell count, lymphopenia, and that if patients have a cell count of less than 500, they have a 3-fold increased incidence of serious infections compared to patients that have a normal cell count, lymphocyte cell count of above 1,500. Other risk factors that were shown to play a role is a higher tofacitinib dose, and also a lower physical function measured with the HAQ-DI, and this is something we also see in our registers. And glucocorticoid use was also a risk factor for serious infections, as were comorbidities like higher BMI, diabetes, and COPD, all risk factors that we also see in other treatments. Herpes zoster was also investigated with those authors and in the data, and you see with an incidence rate of 3.6 that this is nearly a 3-fold increased incidence compared to the rates we see in BDMA treated patients of around usually 0.8 or 0.9 per 100 patient years. And what is, but this could be, and this is the class effect of the JAK inhibitors. And what is similar to other investigations is that we have around 10% of the patients with a herpes zoster that have a complicated herpes zoster course. Other events that were looked at were malignancies, non-melanoma skin cancer, venous thromboembolism, and adjudicated MACE, major cardiovascular events. And all the rates that we see here, 0.8 for malignancies, 0.6 for non-melanoma skin cancer, 0.3 for venous thromboembolism, and 0.4 for MACE are similar to that rate that we see in BDMA-treated patients. So the conclusion of the authors is that the rates of safety events were generally similar to those reported for BDMATs, except for herpes zoster. The limitation of a type of this type of study is that there are no direct comparators within the design. So the next one is that patients included in randomized controlled trials are strictly selected and are not every time representative for the patient population we see in the practice or in real world. Then we have to also think about that the studies were performed in different times, in different time periods. They also have different durations, and we have to deal with drug survival bias. All those limitations are also true for this study. The next one I want to point out, which now looked at baricitinib, another JAK inhibitor. Here, 10 studies were included, 9 RCTs and 1 LTE trial. And also, again, with a maximum exposure of 9.3 years, median was 4.5 years. And what you can see here with rates are the same or are very similar to those rates that I just had shown you. Serious infections, incidence rate of 2.6, herpes zoster 3.0, MACE 0.5, and all the other ones that I don't have to read to you, but they are really similar to the rates that we have just seen. And what was different in this study, that there was also investigation of the dosages, like do patients with a 4 milligram dosage of baricitinib, do they have more serious adverse events? And there was no dose difference. 80% of those patients studied had an exposure of 4 milligram baricitinib. And when you look at those rates, there is no statistically significant difference. So, as I said, the same limitations as in the other study are also true in this study. Another investigation of baricitinib safety, cardiovascular safety, looked at the RA-Begin, RA-Beam study, and also extra the placebo-controlled phase of those study. And what was intriguing was that in this placebo-controlled arm at the first 24 weeks, there was an imbalance of the DVT-PE occurrence, which was not seen anymore if all the data analysis was then integrated in the set. But if we look at this placebo arm, then there was maybe a signal, which was not seen after the switch to the comparator. So when we look at this FDA labeling and warnings afterwards, we first have the question, why did these warnings occur? Because the first warnings already came in 2012, and then there were a series of warnings that I will show you. And when we now look at the data, which is not so different from the data that we expect from biologic DMAT-treated patients, then we have to go back to the randomized controlled trials at the early phases or at the early studies of the JAK inhibitors. And here there were signals mainly in the tofacitinib dosage group of 10 milligram twice daily, which is not the one that we use for the treatment of RA. But here VTEs had a venous thrombotic events had a signal, and that was why, and also some other events occurred. So that was why the FDA urged Pfizer to do another safety study, the oral surveillance study, which we were talking about in detail in the last webinar. And here also a statistically significant hazard ratio occurred in the 10 milligram dosing group. but no statistically significant in the 5 milligram tofacitinib group. So also some other events in the baricitinib and placebo-controlled studies looking or showing a VTE imbalance occurred. And then the numerical higher risk for MACE, which was non-significant in the oral surveillance, and significantly higher risk for malignancies in the oral surveillance, prompted the FDA and the EMA to select patients to say to all physicians and rheumatologists to select patients for the entire JAK inhibitor class cautiously. In contrast, we have multiple systematic reviews that showed no increase of VTEs and MACE, and we have also some real-world evidence. And this is what I want to show you now. Real-world evidence stemming from claims data and observational studies, registries, and in this analysis, looking at baricitinib compared to TNF inhibitors, this is a French study. Both data sources were combined. 3 registries and 11 claims data sets were included in this study. And you can see venous thrombotic event rates of 1 with a hazard ratio of 1.5, which is statistically significant from the TNF inhibitor risk. So for VTE, there was a significantly increased risk with baricitinib, which means in absolute numbers, if you treat 1,000 patients with baricitinib instead of TNF inhibitors, you will find 3 additional VTEs. So the number needed to harm is around 333. Also, MACE, major cardiovascular events and serious infections, were analyzed in this study. And as you can see here, there was a numerically increased but no significantly increased risk found in this study. The limitation of this study was that there was a short duration of exposure with a mean of 9 months under baricitinib treatment, which is not so much regarding our long-term treatment that we need for our patients. This is another French study with claims data, and they have a quite innovative design, I have to say, because they used the patients as their own controls. They had the JAK inhibitor prescription period, but they had also the pre-exposure period. They had the post-exposure period, short-term 30 days and long-term up to 60 days after stopping a treatment. And what they found out, they were looking at venous thrombotic events and arterial thromboembolic events. And what they found was that compared to the pre-exposure period, there was a higher incidence during the exposure period, which was then in the post-exposure period going down again. The same for the arterial thromboembolic events, also here a higher rate, but not a higher rate in the exposure period, which was then getting again lower in the post-exposure period. But I have to say, none of those increases or decreases was statistically significant. Another French study from claims data showed that there was an increased incidence of major cardiovascular events and venous thrombotic events in the JAK inhibitor treated patients compared to adalimumab treated patients, which was not significant, this difference in the MACE, but was significant regarding the venous thrombotic events. In the venous thrombotic events, we can see in the baricitinib treated patients that there was a disproportional rate in the pulmonary embolisms, which was much higher in the baricitinib treated group, pulmonary embolisms regarding to venous thrombotic events, also compared to the other treatments. But adjusted for several variables and patient characteristics, the Cox model showed that there is no significant increase for either of those events, for JAK inhibitors in comparison to TNF inhibitors. The authors performed a lot of subgroup analysis also in older patients, and what was expected was shown that in older patients the incidence rates increased, but there was no significance between JAK inhibitor treatment and TNF and adalimumab. So the risk did not differ. Another, this was also shown in another analysis from the US, from the COEVITAS register. Here are venous thrombotic events, the incidence rates in patients treated with tofacitinib compared with patients treated with any kind of biologic. And here the rates were in all events that were looked at similar and no difference. This is in contrast to a Swedish study, and they found that during JAK inhibitor treatment, the rates of venous thrombotic events were significantly higher than in all the other biologics, except for interleukin-6. Here, it did not reach statistical significance, but for compared to all the other treatments. They also found that 50% higher rates from VTEs in males than in females, and a 9 times higher risk in patients with prior venous thrombotic events. This Kaplan-Meier curve shows first the general population rate and the events occurring there, and you see you have a lower risk in the general population for VTEs than in patients with rheumatoid arthritis. These are patients with RA treated with BDMARDs, any kind of BDMARDs, and these are the patients treated with JAK inhibitors. And you can see here more events occurring in a shorter time. The overall rate of VTEs in patients treated with JAK inhibitors was therefore significantly increased compared to TNF inhibitors, but this increase was mainly due to pulmonary embolisms. And this adds to the concern regarding cardiovascular safety of JAK inhibitors, but the authors also say this must be weighed against the risk of inadequate treatment of disease activity. A study that I also introduced last time is the STAR-RA study. 3 claims databases from the US were investigated, and MACE was investigated in this analysis, the occurrence of major cardiovascular events. And you see in the non-selected population cohort, there was no significant difference. There was also no significant difference in higher risk population, but you see that the estimates get more to that tofacitinib might increase the risk of further major cardiovascular events, especially when patients had a previous cardiovascular event, which is shown here, that patients, and not in patients that did not have any cardiovascular event. Here we can see the estimate that is even in a beneficial area for tofacitinib treatment. So coming to the FDA labeling for JAK inhibitors, we had a lot of drug safety communications from the FDA starting in 2012, and the last ones were in 2021, and in the one from September 2021, they addressed serious heart-related events, risk of serious infections, cancer, blood clots, and death for JAK inhibitors, and this should be addressed in product labeling. They required new and updated warnings, and now for other arthritis medicines, in addition to Xeljanz, which already had a warning, They also now said that for baricitinib and upadacitinib, Olumiant and Rinvoq, that they also should add this warning in their product labeling, because they said there are no studies of these substances, but they share mechanisms of action with xelians. And so the FDA considers that these medicines may have the similar risks as seen in the xelian safety trial, and they meant the oral surveillance study. So MACE was added as a new box warning in December 2021, and revisions were made for mortality, malignancies, and thrombosis. And what was also added was a prescribing restriction, which is not in place in Europe, but required from the FDA for RA patients, patients with psoriatic arthritis, and patients with juvenile idiopathic arthritis. There's an update required that JAK inhibitors should only be prescribed after one or more TNF blockers, after they had failed or if there's an intolerance to it. So, and this time arrow shows you some differences between FDA warnings and European circumstances, which we will hear from in the talk from Chris Edwards in short. And this was that in 2012, tofacitinib was approved from the FDA in the US, but not in Europe. But on the other hand, baricitinib was approved in Europe at the same time as tofacitinib in 2017. But in Europe, there was an approval of 4 milligram dosing, which was not in the US. Filgotinib was approved in 2020, which was not approved in the US. And these are the box warnings and the warnings from the FDA. And you can see the first one was in 2012 for serious infections and malignancies. The next one in 2019 for mortality and thrombosis. Then they required an updated box warning. And in 2021, all JAK inhibitors were included, and the prescribing restrictions that JAK inhibitors should only be prescribed after TNF inhibitor failure was also added. So this is my last slide, my summary. There, the labeling and warnings of the FDA are different from the EMA, and we still have very conflicting results on VTE, MACE, malignancies, and under treatment and exposure with JAK inhibitors. And most of the real-world data does not show significantly increased risk, but we don't know if this is already because patients are stratified of the rheumatologist before they get the treatment. And this is why we need especially more granular data to be able to individualize our treatment, because we still want to, our aim is still to the best and adequate disease control. And thank you.
Thank you, Anja. That was brilliant. Really nice run through all the data, the breadth of data we have, and then the FDA labeling. So that leads us nicely onto the next slide. Sorry, the next talk by Chris Edwards, who's going to take us through the European PRAC review. Chris, thank you.
Thanks very much. Well, it's a pleasure to follow Anja. It's great to see that summary of all the data, and I really like seeing the timeline, which allows us to see difference. And I'll come back to the theme of differences between different regulatory authorities and what that might tell us about the decisions that are made and the human element, how we interpret the information that we see. So I'm going to talk a little bit about the background to risk and benefit with JAK inhibitors. I'm going to talk about the PRAC review and the results of that and where that is in the further processes of the EMA. And then try and link that to how around the world some of the recommendations and guidelines are being altered as a result of this information, which also highlights maybe different ways of producing recommendations and guidelines as well, whether they're done on a 3-yearly basis, which has tended to happen for rheumatoid in Europe, or whether they're living guidelines like the Australian and perhaps the Canadian as well. Okay, so here are my disclosures. Okay, so this slide is just to highlight a couple of things, really. I suppose the first is to say what we're talking about, and these changes in regulatory advice from different parts of the world are examples of pharmacovigilance occurring in real time. It's what should happen. We launch drugs, we start to use drugs, and then data comes in and we start to reanalyze information. We get real world data. Studies get mandated, like oral surveillance, by the FDA, and then more data comes along, and we have to make up our mind how we use these things, how we apply the medications in real world. The other thing, which I've alluded to already, is that there are sometimes differences between different parts of the world, and that doesn't mean things are absolutely right or wrong. It means there's an element of interpretation, and I think where there is, it means there is a bit of uncertainty, and people are trying to decide on the basis probably of exactly the same data, probably being looked at in a very similar way, but maybe in slightly different healthcare settings and different legal settings, how to make the best judgments about future use. And then it is left to us to try and decide clinically what we advise our patients and what we might do. Okay, so this is the risk benefit bit. And I think it's always worth saying we're not just thinking about risk. And we're going to talk about risk a little bit more in a moment. And Anja has beautifully shown some of the risk data. But this is just to remind ourselves that there's also lots of efficacy data around the use of JAK inhibitors from famous studies like Strategy, Oral Strategy, RA-Beam, Select Compare, and the Finch studies, looking at head-to-head studies against the TNF inhibitor adalimumab. And the statistics, depending on how it was organized and how it was done, showing at least non-inferiority and for some endpoints superiority as well. And I think it's really important that that isn't lost in the discussions that we're having, that there is a benefit also to the risk. Oral surveillance has been mentioned. I don't want to spend ages talking about this because you've seen lots of this already, and Anja's mentioned this as well. Just a couple of things I think to pull out. One is just to think about the fact that if we're trying to risk stratify patients to have JAK inhibitors or not, the greatest risk associated with using JAK inhibitors, certainly in oral surveillance and for tofacitinib, was age greater than 65 years and smoking. And that accounted for a lot of the risk that was seen. And if we think about how we might stratify as we come to see how recommendations play out their advice, then perhaps we can use simpler methods of stratifying than using complicated cardiovascular stratification systems that our cardiology colleagues might use. The other thing to think about is that, of course, this study it's a relative risk, isn't it? It's a risk looking at tofacitinib against an anti-TNF, depending on whether people were in the US or within Europe. And Anja has mentioned numbers needed to harm for one of the other studies she's shown. But it's always interesting to look at what this means in terms of numbers needed to harm, numbers needed to treat if we were looking at efficacy. And you can see the data here. So, for example, with tofacitinib compared to TNF over a 5-year period, one additional MACE required an extra 113 individuals, or for cancers, an additional 55 individuals over that time to be treated. So that's not to diminish the risk, it's just to put it in context. Okay, so let's come back to the main part of the talk, which is to think about what is PRAC, what was the PRAC recommendation, and what does it change? And this is really all about weighing risk. It's about risk benefit and deciding how much risk we take for an individual patient versus how bad their disease is, and how important it is to pursue the sort of strategies and principles that we usually use when treating inflammatory disease, like treat to target. And I think it's probably interesting to just take a little bit of time thinking about the process of coming up with these sorts of recommendations in regulatory agencies and what the advice consists of. So here's a slide taken off the EMA website, and this looks at the PRAC process. So what's PRAC? It's Pharmacovigilance Risk Assessment Committee. And they're charged with being asked to look at reviews of particular therapies, and they carry it out in a particular way. So if you look at the slide, you can work from left across to right. They pull information when they're doing a review from various different databases. So that's the hard data of pharmacovigilance databases, the scientific literature. But then there's a very human element. There are patients involved, there are healthcare professionals, and other academic and researchers, and then industry has an involvement as well in this. And all of that is reviewed and it's all considered, and that leads to a recommendation. So what was the PRAC review around JAK inhibitors? We see on the left-hand side, this is the cartoon on what they did. So the different groups involved, with advice being sought from expert groups of rheumatologists, dermatologists, gastroenterologists, and patient representatives as well. And they looked at the data, much of which has already been described. And they came up with a few recommendations as a result of this. So they confirmed the tofacitinib association with increased risk of MACE, of cancer and VTE that was seen in the oral surveillance study when compared to TNF inhibitor. And once again, that relative to TNF inhibitor bit, I think, is really important. And the other thing that they thought is that they would conclude that these safety findings would apply to all the JAK inhibitors being used to treat chronic inflammatory diseases as well. So if we look a little bit more at the detail of that and the things they suggested that should be done to reduce the risk of side effects associated with JAK inhibitor use, they also talked about restricting therapies in patients at risk if no suitable alternative, so this is slightly different language to the FDA, so rather than use a TNF inhibitor first, this is if no suitable alternative is available, and particularly take into account these risks, 65 years or above, increased risk of major cardiovascular problems, smokers, and those with increased risk of cancer. And then the last point there is also to keep in mind those with increased risk for blood clots, for VTE events. Okay, so that then feeds into a broader process, and you can see the timeline of this. So there's the PRAC review, the procedure starts, it's under evaluation, the PRAC makes its recommendation. Then it goes to the Committee for Medicinal Products for Human Use, CHMP, and they've ratified that recommendation from PRAC, and then there's a process of sign-off before labels are changed on drugs. One thing that I think when I read the PRAC initially that we'll come to in a moment is a little think about doses, which I've put in here as this extra box. So further, the doses should be reduced in patient groups at possible risk. So this idea has been added in as it's gone to CHMP around thinking about using the lowest dose possible. And I think that's interesting in the discussion of what doses are allowed in different parts of the world and what the FDA says versus what the EMA has said up until now. Okay, now this is some slides that are not based on science. This is me thinking, well, how would you interpret this and what are the sorts of things you might say? And I haven't put all of the possibilities. So imagine you have a patient with rheumatoid arthritis as a result of this and they fail their CSD-MARDs. What do you do next? And would you do different things? Here's a low-risk group of patients on the left-hand side. If you had high-risk groups of patients in terms of the risk of MACE or thromboembolism and malignancy, and where would you use things? And there is this difference between FDA and EMA as well, where FDA is saying use a TNF inhibitor first, and then the EMA and then the EULAR recommendations are more about if you don't have alternatives and if you consider the risk, then you might use JAK inhibitors or biological therapies. And we'll come to the sort of detail of that. And it's interesting when you look through the medical press and how they start to interpret these things in slightly different ways. So we'll come back to discussing that. So what about how those sorts of readouts from PRAC, from CHMP start to influence guidelines? Well, the most recent EULAR recommendations were already in process when the PRAC process was going on. Here's a couple of bits of information. On the left-hand side, this is the 2019 EULAR recommendations, and this is recommendation 8. And this was the recommendation, the year of the recommendation, which considered biological DMARDs and TSD-MARDs, so JAK inhibitors, to be equivalent. And they were put in the same place. And then you can see this adjustment. And being in the room at the time of the discussion, there was really interesting discussions with some people feeling we should say that everybody should use a TNF inhibitor first before a JAK inhibitor, those that wanted greater flexibility. There were clinical voices, there were patient voices in this. And this was the wording that then was ultimately agreed on. If the treatment target is not achieved with the first CS-DMARD strategy, when poor prognostic factors are present, a biological DMARD should be added. JAK inhibitors may be considered, but pertinent risk factors must be taken into account. So let's walk our way through the EULAR recommendations, which you'll know well. And I think there are a few points worth making as we go through. So we start off with the bit you all know about. Usually it's methotrexate, maybe another CS-DMARD, and we try to achieve a target of at least low disease activity. But if we fail and someone has poor prognostic factors, and I think when we're considering risk benefit, this is worth thinking about, because the people that are going to get a biological therapy or a JAK inhibitor are selected out on the basis that they are likely to do badly because they're seropositive, they have high levels of disease activity, and they failed other CS-DMARDs, for example. And you can see that the new recommendations say add a biological DMARD, consider JAK inhibitor use, but only after you've done the risk assessment. And then that plays through to, if you fail the first level of advanced therapies, into thinking about the next biologic or JAK inhibitor. I thought I'd just zoom in on the risk factors that are mentioned. And once again, it's just highlighting this: over 65, smoking, cardiovascular risk, malignancy risk, previous malignancy, thromboembolic disease in the past. Okay, now if we're thinking about regulatory authorities and how they influence recommendations, it's quite interesting to think about different ways that recommendations are produced around the world. So the EULAR recommendations have usually been reproduced every 3 years or so when there's enough data to warrant a change. The Australian recommendations currently are a living recommendation, which use some different software, and it's interesting just to have a look at it, but it gives the opportunity to modify this quite quickly if you get changes from regulatory authorities. So here's a sort of standard old-fashioned paper reference to one of the things they looked at. So this was tapering, and you can see the authors there. And Rachel Bookbinder in Monash has run this program along with the Australian Rheumatology Society. So here's taken off the website. So they use an app called the Magic app. And actually, if you had this live, you'd be able to look at the bottom row and you could press on evidence to decision and the rationale and practical information, and people have an opportunity to feedback. But you can see on the right-hand side, it says new, and this is looking at the use of biological therapies or JAK inhibitors when people have failed their first TNF inhibitor, for example. And very quickly, they were able to modify this version, which was republished on the 14th of December last year, to add that last bit in, which is in particular, JAK inhibitors may not be preferred in those who are at higher risk of cardiovascular disease or cancer. Okay, so that's me done. So I think we talked a little bit about pharmacovigilance and how this is the process as it's meant to happen. We're meant to find information and we're meant to then weigh it up. So I see that, as a positive thing that we're working our way through this. We've talked about the PRAC and EMA process, which hopefully adds on to the information we've had about the FDA and where that is, and to start to try and think about how does that influence what we do and how do we weigh that against the efficacy benefits. And make that personalized to each individual's. And then a little bit about how that might alter recommendations and guidelines around the world, and how perhaps, living guidelines, just out of it, allows you to make those changes so quickly, as illustrated by the Australian guidelines. And finally, just to say that the fact that there's difference around the world gives us this opportunity to ask why and to use those questions and answers to really inform how we treat patients. So thank you very much.
Thank you, Chris. Great again, and I think reviewing and highlighting the differences in the recommendations is really instructive, as you say. So finally, to the last speaker, Lorenzo, pleasure to introduce you today to give this last talk that's really going to pull it together in a sense and give clinical pertinence in terms of implementing regulatory updates. Thank you, Lorenzo.
Thank you very much, Maya, for your introduction. And I will be discussing with you some concepts and idea to how implementing real world and real life those regulatory updates. And this job is really has been made more easy by the two wonderful presentations that preceded me. So I say if we can go on. Perfect. So as every one of you know, there are two major key principles of rheumatoid arthritis treatment, and they are the tight disease control and then the consequent treat to target that is a kind of derivation of the first concept. And as you perfectly know, the tide control has been formalized back in 2004, and with a very, let's say, groundbreaking but simple study that showed that if the patient randomized from intensive versus routine care, assessed monthly by an objective system of measuring disease activity, when there were track of having a significant disease activity, there was an escalation of the treatment itself. And then those patients were evaluated independently every 3 months by an independent assessor. And as you all know, patients that were treated with a tight control of the disease did better in terms of all the descriptors that was considered, including Euler-Guss response, transmission, and the different ACR 20, 50, and 70. And as you can see here, the disease activity was significantly lower in patients receiving an intensive evaluation. The treat-to-target concept came a little bit later. This paper is from 2010, and actually formalized the way in which we should work to obtain the tight control of the disease. And indeed, the task force suggested to establish a target of disease activity for each patient, which should be remission. In some specific patient, a low disease activity could be also accepted. But again, patients should be treated and re-evaluated at least every 3 months, ideally every month, and the disease and the treatment should be escalated when we do not reach the specific target. And hoping and aiming to put the patient in a status of sustained remission or sustained lower disease activity that was the specific target. And according to that, a lot of recommendations have been developed, including the Euler recommendation. This is the very last one that has been already cited by my colleagues before. And as you know, and as you remember, those principles are perfectly applied, and also a specific position came there after the studies, the oral surveillance studies and the data that emerged on baricitinib, with a specific sentence saying that when you want to treat a patient after conventional synthetic BDMARs with a JAK inhibitor, then you should be considering a number of risk factors, namely age, history of current or past smoking, cardiovascular risk factor, risk for malignancy, and for thromboembolic events. And the wording is significant because it's slightly different from what actually it came out from the PRAC CHMP opinion, in which actually the wording is slightly different, and they said that JAK inhibitors should be used only if no other suitable treatment are available in the same group of patients. And this is somehow a little bit something that we should be keeping in our mind. And indeed, before the PRAC guidelines, I would say we know that JAK inhibitors are extremely effective drug, and they have a significant efficacy and a significant effectiveness in real world. And they were widely used after the first conventional synthetic BDMAT failure, but also after BDMAT failure, and also after a failure of another targeted synthetic DMARD. There was a specific interest in monotherapy because clearly these are JAK inhibitors, is just the other class, together with interleukin-6 inhibitors that are approved to be used in monotherapy. Some specific subjects have a specific interest because they may be benefiting for the usage of this drug also because they have some specific comorbidity that could respond to JAK inhibitors, or some specific subject may be preferring to take an oral drug instead of having an injective drug for a number of reasons. And there was a significant attention just in patients with a history of VTE. After the PRAC determination, probably the attitude of physicians prescribing those class of drugs has changed, and indeed there was a significant reduction of the use of those drugs after conventional synthetic drug failure as first-line drug, probably also a slight decrease after first BDMARD failure and also after targeted synthetic BDMARD failure. Clearly, the driver for monotherapy and the attention for monotherapy is still an important driver, and so it maybe move a little bit earlier in the list of the prescription drug for those patients, and the attention is widened to a largest number of patients, as my colleague pointed out perfectly before. Clearly, this was driven by an idea. First, we don't want to harm our patient. And this is clearly the principle that guide every physician in making a decision. But I honestly speaking, with a number of physicians involved in the treatment of patient with rheumatoid arthritis, probably a little bit, there's also an addition to this sentence from Hippocrates, but this is my translation into Latin, which means first, do not harm yourself, dear doctor. So think also of yourself. And indeed, this worry about JAK inhibitors that came out from the regulatory information, whatever, started a number of behavior that in some instances are a little bit strange. For example, I know of some physician that actually started with quite a defensive attitude, namely using, for example, an informed consent from the patient. Clearly, every decision about a drug treatment should be a shared decision between the patient and the physician and the caring physician. But it's completely useless to actually ask for a patient if he or she has no risk factors to sign an informed consent just because there's some data in a specific population, if not worrying the patient. And also, I mean, if you discuss with the patient and write down that the reason for which you decide to pick up a JAK inhibitor, even in the presence of other attention or contraindication, is something that should be objectively motivated, even without the consent. You need to discuss with the patient clearly, but it's not needed to have a written consent. The second point that to me is something that we have to think of is that the risk for that is to adhere less to tight control and treat to target. Since we know that this drug are effective and may be extremely effective in some specific subtypes of patient, delaying that may be placing a patient at risk for problems connecting not to a perfect control of the disease. And there are a lot of evidence. These are quite old data showing, for example, that if we start later an effective treatment for rheumatoid arthritis, we have a lower chance of putting the patient in remission versus if we start early. And we perfectly know that as soon as an effective intervention occurs, we are not only able to stop inflammation in this patient, but we are also stop the progression to reduction and loss of function of the specific patient. So an early effective intervention as soon as possible is one of the major determinants of prevention of long-term disability. And also we do know, and this is again an old study, that one of the major correlates for probability of survival in rheumatoid arthritis patient is the level of disease activity, independently from the type of drug that we use for control the disease activity itself. And patient having a minimal disease activity has roughly half of the risk of dying than patients that have a severe disease activity a long time of follow-up. And we know that, and also not only disease activity, but for example, as is shown in the lower part of the graph, the number of active joints in the joint count here, or the limitation of activity of daily living that is here, correlates with mortality. And also in the same way that for coronary artery disease or Hodgkin disease, there's a correlation with the different stages of the disease. Another more even risky fact that can happen is that even if we don't have a perfect control of disease activity with the drug, with the DMARD, we add some non-DMARD drug that may be impacting on mortality and also on cardiovascular mortality, for example. And I give you an example. It's quite well known that the use of cortisone, of prednisone, increases the risk of mortality in patients with rheumatoid arthritis. And we perfectly know that, for example, patients that are treated with methotrexate have a reduction, a protection, and as you can see here, a protection toward mortality if they receive methotrexate. But if they receive prednisone and methotrexate, prednisone is able to abolish this advantage in mortality that is given by methotrexate. And if they've received just prednisone, this is again something that will be increasing the mortality. And the same concept could be extended, for example, to another drugs such as sulfasalazine. This is even more clear in this study that actually compared a population of rheumatoid arthritis patients having diabetes mellitus or not having diabetes mellitus, treated or not with glucocorticoids. And as you can see in this table, we know that giving patients glucocorticoid, if they have diabetes mellitus, independently of whatever they are taking and on their disease activity, increases significantly the risk of death for all cause by 3 times roughly, and by 2.3 times the specific cardiovascular mortality. And these data are even more evident in the population that has not diabetes mellitus in the background, since there's a reduced by baseline cardiovascular mortality. And as you can see here, the risk is 4.37 and 3.29, and this is statistically significant. We know that adding a non-steroidal anti-inflammatory drug to rheumatoid arthritis is not varying the risk of cardiovascular mortality, and there's no sign that addition of NSAIDs to treatment increases cardiovascular mortality. But this is true in all patients and in general. If we consider, for example, patients that have some specific cardiac conditions, such chronic heart failure, you can see here that the adding of a different NSAIDs, a therapeutic dose, will be increasing mortality and increasing significantly, not just by some standard deviation as shown by JAK inhibitors, for example. And the same thing is even worse if we consider patients that are taking anti-inflammatory drug after they have a myocardial infarction, or if they have an history of ischemic cardiac disease. And you can see here the difference are statistically significantly different from the patients that are not receiving the treatment. And if we go back to the same graph that my colleague shared with you before, we remember that there was a signal, a clear signal that we should be taking in consideration. I'm not saying that we should be giving JAK inhibitors to the specific population, but again, take in your mind how significant was the risk for corticosteroids and for NSAIDs in patients having a background cardiovascular disease as compared to what we see in both the oral surveillance study and the STAR-Array study. So what should we do practically when we have this information coming from the scientific literature and from also the position from the regulatory agency? I would say that probably we should be putting together, clearly taking in strong consideration the indication that the regulatory authorities are giving us, but merge them with a good dose of clinical common sense, like the one that, for example, has been expressed by the expert of EULAR when they formulate the guidelines, saying that we should be taking in consideration those specific aspects, as we did every day, I would say, for every drug. If we administer a drug to a patient, we should be thinking of all the potential risk and benefit of the drug. Indeed, we know that JAK inhibitors showed efficacy and effectiveness in conventional synthetic DMARD and BDMARD failure. The response is quick and maintained over time, and in many instances, this could preventing us from the use of corticosteroids as bridging therapy. They have significant efficacy and persistence even in monotherapy. Also, I would say that clearly acting from the prudence side, the PRAC and the CHMP prefer to give a kind of regulation that apply to all JAK inhibitors. But we also know that different JAK inhibitors may have different specificity due to their different inhibition profile of specific cytokines, and the drug ideally could be different. So this is something that should be studied and not taken without criticism. And since this is true, it's at least thinkable that efficacy and safety profile may be different in individual patients. Clearly, we need to go for specific and generic guidelines. We do not go at that level for the single patient. But again, when we have to make a decision on the single patient, we should be taking in consideration this. And clearly enough, the ongoing safety recommendations are useful, but are pushing us again to a greater consciousness for having a personalized, agreed choice on the drug that we're giving to the patient, discussing with the patient the potential risks and benefit, and do not just trying to defend ourselves to the risk of giving something that may be somehow harmful, when in some instances not treating a significantly active disease may be even more harmful for the patient. And also, we should be considering the evolving clinical knowledge and data on JAK inhibitors. And having said that, I'm provoking you a little bit with the study. The study was published in 2013 in the American Journal of Medicine, and actually it shows the differences in terms of side effects, and specifically, as you can see in the top for the composite cardiovascular outcome, of a class of drug that I've covered here against TNF inhibitors. And as you can see here, the favor in terms of composite cardiovascular outcome is statistically significant. So a more strong signal than what has been seen in the oral surveillance studies favoring TNF inhibitors. And then this class of drug are non-biological drug DMARDs, and most of the patients were on methotrexate in the study, as you can see here. And again, this is something that is not forcing us not to use methotrexate, but is forcing us to understand that if we stick on methotrexate or another conventional and synthetic DMARD, probably we will be not controlling the disease. And if we don't control the disease, again, we have this problem that is shown here perfectly in this graph. So if you have a patient with a severe disease activity, he has a doubled risk of dying for whatever cause than a patient with minimal or who is in remission. And the same concept is depicted in the graph that shows you that if we treat to target our patient and versus we go for usual care, the patients that are in usual care are an incidence of fatal and unfatal events that is definitely and statistically greater to patients that are treated to target. So we have to put together the guidelines with the data about disease activity. And probably, when I conclude my talk now, by taking out one of the graphs that I showed you provocally last time, depicting how the clinician in general over time may be modifying their attitude toward the drug or JAK inhibitors in specific. At the very beginning, we have a kind of intermediate perception of the drug. Then data came out and we think that we can treat everyone and everybody with this drug. Then some side effects came out and the general opinion is thinking that that specific drug is a poison, but probably the truth is between those two extremes that are extreme. So the drug may be useful if we give this drug to the right patient at the right time and at the right dose, keeping in mind that we have to control the disease as the first mission to preserve function and to also reduce mortality and morbidity in our patient. And I thank you for your attention.
That's brilliant. Thank you, Lorenzo. Really raised lots of relevant clinical issues, and it really takes us nicely on to the discussion. We'll bring the rest of the panelists as well to take part in this session. We have a question or two coming through. I'd really encourage all of you attending, there's many of you, I'm sure there's questions you'd like to ask, so please don't hesitate to put your questions down in the Q&A. So we'll kick off with, I'll bring this to you first, Chris, if that's okay. So the phrase, unless no suitable alternative treatment is available, what does that mean? Does it mean that JAK inhibitor should be an absolute last resort in at-risk patients? Or is it placing the decision into that shared decision-making process? So there's lots of concepts in that, but it's a fundamental question.
Yeah, and I think it's always really interesting how people read these things differently. One of the things I was trying to allude to, those little cartoons I drawn, is trying to bring out some of the differences in the reporting in the medical press, because some of the reporting says exactly the more extreme version of how you interpret this, that it means try every single thing first, try every single biological agent. Now, that's personally not how I interpret that. I think it's about deciding what's alternative in a particular individual. So for a particular individual, maybe they tried a different drug, maybe they don't want a particular drug, maybe they have a particular risk factor that's a concern, like a high risk of TB, maybe they absolutely don't want to take injections because they properly are needle phobic. Now, that's not loads of people, but as an example. So to me, I interpret it as being an ability to be a little bit flexible and to say, let's weigh it up with the individual. There's a very nice phrase in an article I read yesterday, which is about, this is about getting to treat to, not just treat to target, but treat to agreement. It's about getting the agreement of the patient to consider what's an alternative for them. So anyway, that's how I would interpret it, but I quite like it where things can be interpreted in different ways. I think that shows we need to think about it rather than being prescriptive and saying, just do this.
And that's the nature of medicine. That does bring the art into it. It's always paraphrased as. And Lorenzo, you really spoke to this as well, because I suppose what Chris was highlighting is that it's not necessarily looking through the lens of JAK inhibitors and cardiovascular risk, but also ascertaining risks of other therapies in the context of the individual patient that may have a range of comorbidities.
Yeah, I mean, it could also be if you need a very effective treatment, then you could also say, okay, I need this effective treatment now. Sorry, Lorenzo, but I just
yeah. No, I mean, Lorenzo, you spoke about glucocorticoids. Often we forget that, even in the area of targeted therapies.
Exactly. So my personal feeling is that I agree completely with what Chris said before, and about the fact that we need to use our mind, our cleverness to find out the exact treatment, the perfect treatment for the patient, discussing with the patient without some specific request. A patient being completely afraid of needles, some of them are there, and then you risk to prescribe something that is injective, and then the patient is not using that, or the necessity of using methotrexate on background, which is another problem. And we know that many of the data that have been generated are generated with methotrexate plus. So I'm not saying that we should be forcing the decision and not taking in consideration the guidelines, which are important. But again, we need to work and think which is the best strategy for those patients.
Yeah.
Maybe if a patient has let's say, a rheumatoid arthritis that is slightly, I mean, is not perfectly controlled, but by the first lines in conventional synthetic, then clearly there will be a number of different options. But for example, a patient with a significantly active disease that is intolerant to methotrexate or other conventional synthetic, I mean, clearly we should be moving according to other guidelines to an interleukin-6 inhibitor or to a JAK inhibitors. And so we should be weighting the two things together. So again, we need to use our mind or our cleverness in order to pick up the right drug for the right patient at the right time.
Yeah, and we may come on to patient perspectives. So Chris spoke about the shared decision as well. We'll come on to that in a moment. I'm just seeing a raft of questions coming through, which is good to see. So there's this question, it's an interesting one. So based on the data that we have, and this is to you, Anja and Chris, based on the data that are clearly highlighted or suggested, age, smoking, etc., relevant, then for the future of clinical trials, where should that go? Should we be, I mean, that's maybe a question to industry, and I'm sure there's industry attendees here, but should trials be excluding these patients? What are your thoughts?
Oh, no, I don't think that we should exclude too many patients from the RCTs, because then the representativity gets less and less for our patient population that we treat in real world. Or what do you think, Chris?
Yeah, well, I think the same. I mean, I'm always really interested in seeing trials that show the complete population, and the over 65 age group is often, exactly as you say, underrepresented, and the over 75 even less and sometimes excluded. It's why it's really nice when you see some of the real world data, which often includes some of the older patient groups within it. So at that level, I'd really encourage more of people over 65, not less. The flip side of that, though, and I think it's an interesting ethical question. If you were sitting with an ethics committee and you were saying, okay, so the regulatory authorities say you really shouldn't give, imagine it's a trial where it's a first advanced therapy, and they say you shouldn't give it. The regulators say use something else first, and you're putting people in a trial which is against the regulatory guidance. I think that's still an interesting discussion, though, isn't it? I think that's why it's such an interesting question. You could argue that you need to collect data in this group, and therefore it's vital. But the flip side of that is if it's going against what's being said by the regulatory authority, that you'd have to think that through, wouldn't you?
So if it's for a known drug with risks, that's a different scenario. And if it's evaluating emergent or repurposed or other drugs, it's a different question as well.
Then you can definitely use them. Yeah, then no concern.
Because as you said, the reality is we need real life pharmacovigilance. That's what the data is showing. Dose reduction, so there's a specific, I forgot to mention that should trials be anticipating the need for dose reduction or starting with lower dose, I suppose, in high risk populations. That's not just relevant for cardiovascular risk, but do you think maybe trials need to be cognizant of that? Any thoughts? I mean, it depends on the individual drug. It's a bit tricky to answer specifically, but I think it very much depends on individual drug. And I think it's only when data emerge, actually, do we sometimes know. It's no different to TNF inhibitors and biologics. We've learned about these drugs with increasing exposure and experience. So I think that the dose reduction, there's always benefits of it, and particularly in the era of sometimes wanting to dose taper, but also now we're increasingly seeing this paradigm maybe that in high-risk patients could potentially afford to use a lower dose strategy. I think that maybe that's where the question.
Yeah, no, I agree, and I think it's definitely interesting to get more information. Does it mean that a drug that has 2 doses has an advantage over one that doesn't? I'm not sure I entirely read the guidance as that. It says where there's a lower dose, consider using it. However, flexibility has its uses, doesn't it? And I think maybe in long-term extension studies, as has happened to some of the JAK inhibitors, certainly to baricitinib, it's happened, isn't it? In the long-term extension, having a step-down arm, I think that's interesting. You often end up with a small group, so it's perhaps hard to collect statistically robust data, but you get an idea, you get a flavour of the step-down in that.
Agreed. We'll come on to this other question, and I was going to pick it up, Chris, after a comment you made, and then I'll come to Lorenzo as well. So do you advocate Q-risk-3 or other cardiovascular risk scores in our patients and use a cutoff? And I was interested that you mentioned these are complicated, and because age and smoking particularly have been identified, perhaps we should be adopting simplified approaches to risk stratifying. But there's a known unknown a little bit, and these risk factors are validated for clearly identifying those at risk. And one good thing that's come out of, if you can call it a good thing, is out of all surveillance in these data, is the importance of addressing modifiable risk factors to improve the overall outcomes of our patients. So
so I'm not speaking against using I'm using the word complex, I'm being negative immediately, but using a complex cardiovascular risk score straight away. It's just, I was trying to imagine, so in a trial setting, definitely. If I'm trying to answer a specific thing, I may well use it. But imagine I'm seeing a patient, so I do a cardiovascular risk score, then I do a malignancy risk score, then maybe there's a DVT-PE risk score, and already it's the next day. So it's thinking about how you do some weighting. And in fact, there are some nice publications out now where people try to weight it in a slightly simpler way, where they just say, has a cardiovascular risk factor, or has a previous malignancy, or is over 65 or not. And you end up with something that just gives you a steer towards what's reasonable. So it's not complete science, but it makes you think these subjects are important. That's the thing I just think is a bit more difficult with doing all these specific scores.
The risk is it becomes black and white. Lorenzo, your thoughts?
Yeah, I perfectly agree with that. One of the points also is that the surveillance study put together different risk factors, and you have 1, 2, 3 or more, or whatever. I mean, pharmacologically controlled hypertension would be a risk factor weighted in the study as much as in previous myocardial infarction. And probably we need to explore a little bit, and the STAR array study, for example, gave some insights to us to that, about which single risk factor may be responsible more significantly for the increased risk in that population. Honestly, I discussed with a number of cardiologists about the idea of considering as a significantly increased risk a person that has borderline hypertension receiving one drug and is now perfectly controlled. Again, I'm not thinking that this personally, and many cardiologists will be thinking the same, that this is actually a risk factor for a cardiovascular disease. I mean, it's a slight risk factor. Again, if we have on the other side the risk of not controlling enough the disease, I'm quite convinced, and think everyone around this table is convinced, that not having a perfect disease control would be a strongly more significant risk factor for cardiovascular disease in those patients.
They're coming in thick and fast now, so I'm going to have to pick and choose a little bit. So one that's very clinically relevant, I suppose, a patient who's already established on the JAK inhibitor, who then develops a major adverse cardiovascular event. What should be the next step in terms of that RA therapy, the JAK inhibitor therapy? Anyone like to offer? I think even in that scenario, there's no absolute, and it very much depends on, and I think Lorenzo, you alluded to this as well, but it depends on the individual patient profile, what treatment options are available, if any. What treatments have been used, other comorbidities, the importance of controlling disease activity, the risk of losing that if the JAK inhibitor is taken away, particularly if there aren't any others. And Lorenzo, your point about glucocorticoids, we often, in the pre-biologic era, we used to then accept glucocorticoids, and it feels difficult to do that in this era, to condemn someone to glucocorticoids, and the ability for us to very clearly say that the relative risk between these, and I'll bring Anja in a moment, the relative risk of one strategy over another, we don't have those kinds of data. So it's a judgment call. It comes back to the art.
Yeah, I agree with that, absolutely. And again, I think that personalization, as we all are agreeing around this table again, is the key for deciding the best treatment for each patient. And you should be studying all the characteristics that you've included, including also maybe the length, the duration of rheumatoid arthritis, which are clearly the alternatives, and which are the risk of not controlling the disease versus the potential risk of adding something. Clearly, among those risk factors, the only one that seems very, I mean, at least quite significantly influencing the outcome is the history of a previous myocardial infarction event. So with that specific patient, honestly, I would be a little bit more worried, and clearly a history of an active or a recent cancer, as for many other biologics. But this opens another discussion of what to do on those specific patients. But still, I think, again, we can discuss with our patient. I have patients that have an oncological story, and they tell me, okay, I may have an increased risk of cancer, but I don't want to live with this pain. So please do something. I acknowledge the risk of the fact that those treatments, whatever they are, they may be giving me a slightly increased risk of cancer, but I don't cope with this pain and all these troubles anymore. So it's something that, again, forces us to go back to our work of physician, of being doctor, and working and discussing with the patient and obtaining, again, a treat to agreement, an agreed decision of which treatment we should be doing, understanding the risk benefit potential of the treatment.
Yeah, and Anja, maybe I could just come to you in terms of when it comes to interpreting data, we're making sometimes value judgments here when we talk a bit of the art, but how it is about, there are data that we don't know. We only know for now in comparison of JAK inhibitor TNF, that they're the data that are being used to inform our guidance and our practice. But speaking to all these points that we've been making, clinical practice, then going back to the data you showed where there's conflicting data, and how to manage that in terms of how do you as an epidemiologist assess other drugs and potential risk in the context of JAK inhibitor when the direct comparisons aren't made?
I mean, we have a big advantage with our register because we have a lot of drugs included in the same design of study, so we can look at all these drugs. So we could also stratify, for example, patients that have a higher cardiovascular risk, and then look at different drugs that are then prescribed. But we have the limitation that it's observational data, and that the decision of the rheumatologist will drive a little bit which drug is prescribed. So, and the other thing is that if you have a patient population that has a higher risk, I mean, the relative risk is higher than if you have a patient population where you do, so it's sometimes in the patient population where you don't have a lot of risk. Oh, now the others are gone.
Right. Yeah. That's 3 of us still.
and then even a little risk increase is not doesn't count, but in a higher risk population, absolutely, a little risk increase and
that's a really concept. There are a few questions. I'm just mindful of time. There are a few questions that we can tackle together in one go. So questions such as if they're 64-year-olds and going on a JAK inhibitor, or if a patient is already treated with JAK, we address that. But Chris, it goes back to, it's not meant to be prescriptive. So we have to still, there's a lot of question coming through. How do we manage patients if they're 64, want to go on a JAK inhibitor 1 year, and they smoke? And so this is again coming back to that judgment you were talking about and looking more broadly. Is that anything you want to add, or?
So I'm very happy. I don't know how much my signal might be breaking up at the moment.
Oh, okay.
but assuming you can still hear me, you can stop me if it starts to break up. I think what I really wouldn't want is these sorts of things to end up with clinical craziness. And by that I mean we have people and they're one day before their 65th birthday and we have them on a drug, and they hit their birthday and we change it. So I think you have to be a bit flexible about this. Instinctively, I don't want to suddenly change things. It's not that I'm ignoring the risk, but it makes me think back to COVID, where there was a temptation for people and clinicians to stop all the immunosuppressants until we knew what happened. And that would have caused chaos. And so largely we advised that you don't do that. And that turned out to be okay. That turned out probably to be the right way to just be a bit steady about things. I think we do more harm if we start to take people off things rapidly. I just think the next time you see the patient, it needs the discussion, doesn't it?
Absolutely. And that's absolutely, that's the crucial thing. There's a question that says, shouldn't be consenting our patients? And I thought, well, we already do informal consent with our patients. So exactly that, Chris, if that patient comes next time, we feel obliged to inform them and update them with data.
Yeah, but there are some situations. So Lorenzo picked out one, if someone has a big myocardial infarction and they're unstable, I'm going to be a bit concerned about that. That's likely to end up with the drug being stopped and consideration for another drug. But just becoming 65 or smoking a little bit more or becoming hypertensive on treatment, that none of those things are probably going to result in me changing.
In isolation, it's risk factors in isolation.
And what I really liked was that Lorenzo also showed us the risk for glucocorticoids and NSAID. And if we have older patients and then we stop effective treatment and then we treat them with glucocorticoids, I think this is more harm than benefit. So
there's a question specifically for Lorenzo that tight control treated targets obviously extremely important. That's what the guidelines advocate, but the guidelines also fundamentally speak to starting with methotrexate and using advanced therapies in CSD demand failure. So often there's already accrued a level of ongoing inflammation, disease burden. Do you find a conflict in that, or how do you see that in the context of treated targets and what you were talking about in terms of the importance of that to reduce and minimize cardiovascular risk?
That's a very good question. I think that, guidelines are not the, let's say, table of flow. So it's something that's evolving over time. As soon as new concept came out and as soon as new data came out, they should be evolving. At this stage, there's a consensus that every patient should be treated also for an economical point of view, I would say, with conventional synthetic DMARD at first line. And the future will be changing depending on the data. There are data on JAK inhibitors that you all perfectly know suggest that some of them are better than methotrexate as a first-line treatment. And then, we should be taking in consideration also this. There are a number of other evaluations. There are some local restriction that force physicians to have even maybe a second DMARD before, conventional DMARD before going to bio. So there are a lot of factors. But the point is that, again, the guidelines, as it's happening, because they're changing every other year, more or less, need to evolve with the scientific knowledge on the subject and with the scientific data that should be gathered. So I perfectly agree with what is proposed, and also with the wording. It is extremely clever because it's suggesting that you should be taking in consideration, and as I said, as we typically should be doing, whatever, when we prescribe an antibiotic to our patient or decide to wait, when we prescribe some anti-inflammatory drug for pain or whatever, we make a decision and we weigh the risks and benefits. And I think this is just a clear point-by-point description of the fact, and then we should be making the decision.
So a couple of questions over monotherapy. That can we use what we've learned from oral surveillance in the context of JAK inhibitor monotherapy use?
Well, in oral surveillance, there was methotrexate in both groups, I think. I think that's right, isn't it? So
where JAK inhibitors are used as, I think they're asking where JAK inhibitors are used as monotherapy.
Yeah, but can we
do those risk factors, is it still relevant?
Yeah, well, well, I think oral surveillance doesn't give us the information, does it? And it's harder to know. And I guess it depends how much of an effect you think methotrexate has on reducing cardiovascular events. Now, I think it probably does. So, and it's likely to have, whether you use that with a TNF inhibitor or whether you use that with a JAK inhibitor, the methotrexate is probably going to be beneficial in that setting, isn't it? So I'm not sure it tells us completely. I'm not sure it changes what I do. I don't know what the others think.
Yeah, and nearly the same. I was wondering, was there a subgroup analysis of the methotrexate dosages in
That's
the
interesting.
different arms?
Yeah, I'd really like to see that, Anja. I think that's a great idea.
I mean, I would certainly suggest, Chris, that from what you're saying, like you say, there may be some additional protective effects. So if anything, one isn't going to underestimate risk through JAK inhibitor monotherapy, because if you're implying that methotrexate may have a atheroprotective effect, which data certainly show, then the concern with JAK inhibitor monotherapy would be that there's and this is just for the audience, that there is no basis for this, but the theoretical concern is that there'd be an even higher risk because there's no additional protective effect that is perhaps balancing out. I don't know. So you can't extrapolate from all surveillance, but still employ the same sort of caution, I think is what we're all saying.
Yeah, I agree.
There's a methodology question, Anja. I'm going to come to you. So it goes back to the non-inferiority design and the hazard ratio 1.8 and how it was chosen for all surveillance to look at cardiovascular risk reduction. So what do you think that was applied in OS study, and that a statistical evaluation methodology used to assess CV risk reduction of what is traditionally done for oral antidiabetic therapy is then applied here? So is that appropriate? And then applying it to malignancy as well, is that appropriate?
Oh, I think I can't answer this really good, because I think this how this non-inferiority level, this upper margin is chosen. It's a bit, I don't know if there's a real calculation how you can choose it. So because at the beginning you don't know so much about your treatment, and you can take other randomized controlled trials into account, and then maybe also transport some information that you have from other studies, and then you say, okay, this is my upper margin for the non-inferiority level. But I don't think that it is really based on a stable statistical method. So
that's helpful. Yes, it's a tricky one, isn't it? So we've got time maybe for one, maybe two questions. So patient in remission for some time after addition of JAK inhibitor to methotrexate, so they're on combination JAK inhibitor. Would you consider tapering methotrexate of the JAK inhibitor? It's an interesting question. So I don't know whether it's saying, I was expecting maybe to say, would you consider tapering the JAK inhibitor if there are any concerns? But thoughts on that either way around, tapering with JAK inhibitor combination?
If I may, if we're considering a 65-year-old person, I honestly am perfectly in line with what the colleagues have already said, namely the fact that this cutoff age from 64 and 364 days to being 65 is not something so quantic that make me...
To taper drug, if a patient is in remission, would you taper?
Honestly, I will be discussing again with this patient. We have an advantage due to the fact that we know that JAK inhibition, if we stop the drug you have and the patient is getting worse, then you will probably in a short time seeing again the re-emergence of symptoms and of the disease activity. So I would be probably considering tapering down and taking out the JAK inhibitor and re-evaluating the patient for clinical activity. Honestly, if the patient, again, has experienced a flare-up of the disease, I will be discussing with her or him about the reintroduction of the JAK inhibitor or the ideal strategy. Having another information, the patient is over 65, perfect, but we have an historical data that the patient was in remission with a JAKi. So I will be I have an element for strongly considering the class of drug in this patient again.
Yeah. And I think there'd be a difference perhaps in Europe versus the US. The ACR would tend to say, well, look, you needed to add in the advanced therapy. So why would you take the advanced therapy away? Because it worked, take away the methotrexate. I think in a European setting, certainly in a UK setting, we've tended to take away the advanced therapy and leave the methotrexate. But then one of the things Lorenzo said, I think is really interesting, the half-lives of the drugs make a real difference, don't they? So when you stop, or if you're tapering a TNF inhibitor, depending on what it is, it might stay in the system for weeks, months. So you get a very soft landing potentially. You think there's no problem, and then 6 months later, the person flares when they're not in clinic. If you stop the JAK inhibitor, within a week or two, you know. It works or it doesn't. Now, I'm not saying one is better or worse. They're just different because the pharmacokinetics and dynamics are different.
You can get a very clear indication with JAK tapering very quickly whether it's going to be suitable or not. I think that's an interesting answer and question answer to close on. So just leaves me really to thank the faculty for brilliant talks. We've really had a good comprehensive review of the data and the literature from Anja and Chris, also taking us through the guidelines, recommendations, and PRAC evaluation, and then Lorenzo nicely capturing, I think, those patient relevant factors when we have the patient in front of us. I thank you all for your attention and for the great questions. It's been really that much more fun having good questions to generate this kind of discussion. Do please fill in the short evaluation form to let us know your feedback. It's really important because we obviously, CSF and the initiative strive to enhance these educational meetings. And remember, the live stream version of this webinar is now available. So even the first one, if anyone missed that, and also today's as well. So you can see that on the YouTube channel as shown here. So thanks very much again. Take care, everyone. Thank you.